You may submit questions anytime during the presentation by typing them in the question box in your control panel, and we'll be sure to review them as they come in for a Q&A period at the end of the presentation today. And finally, this webinar is being recorded, and we will be sure to share a recording of today's webinar with you so that you can also share it with your network after today's presentation. Okay, so before we get started, just to share a little bit of background about the Hep United Coalition and our partners nationwide. We were founded about 5 years ago by the Hepatitis B Foundation and the Association of Asian Pacific Community Health Organizations. Hep United is a national coalition of over 30 organizations across the country with a mission dedicated to reducing the health disparities associated with Hep B by increasing awareness, screening, vaccination, and linkage to care for high-risk communities. The coalition also serves as a voice for hepatitis B advocacy issues locally and nationally. We advocate for increased resources for hepatitis B prevention and treatment. So members of Hep United are also community-based hepatitis B coalitions themselves, comprised of stakeholders from a variety of sectors. Many include coalitions made up of health clinics, local or state health departments, community social service organizations, as well as academic research institutes. And as we all know, evaluating the effectiveness of stakeholder relationships and interactions as part of a coalition can be difficult at the local or national level, but it is important for us in terms of sustainability and making sure that all of our partners remain engaged. So we thought we met our presenter today, Kanako Kashima, a couple of years ago at a public health conference where we learned about the concept of social network analysis, and we thought that this would be a great way, a great option for all of our partners and ourselves to consider to use in terms of evaluating our coalition relationships. So I'm going to go ahead and introduce Kanako. Kanako is a research program associate for comprehensive cancer control at the George Washington University Cancer Center in Washington, D.C. As part of the Comprehensive Cancer Control Technical Assistance Cooperative Agreement with the CDC, she manages and facilitates state and regional community roundtables that bring together cancer and chronic disease stakeholders and community members, as well as the mentorship program, which is designed to foster collaborative relationships between public health professionals. Kanako also leads project evaluation, technical writing, and reporting efforts. She received her MPH and BA from the George Washington University. So I'm going to go ahead and, turn it over to Kanako.
Great. Thank you so much, Kate, and to the Hep B United for having me today. My name is Kanako Kashima. I'm from GW, and I would like you all for thank you all for having me today. And I'm presenting on using social network analysis to measure coalition collaboration, something that I'm sure you are doing every day, and give you a case study of what we've done at GW with the Community Roundtable. I would like to thank and acknowledge the support of CDC for this work. By the end of this presentation, my hope is that you will be able to define social network analysis in very broad terms, and then describe ways to use social network analysis to monitor and develop relationships and improve those program delivery mechanisms that you may have as a part of your coalition work. So to begin, let's define what a network is. It is a set of nodes or individuals or organizations, and those are denoted by the black circles on your screen. And those are paired with a set of ties or social relations that link those nodes, and those are denoted by the black arrows on your screen. So social network analysis is the study of these social relations among a set of individuals and organizations. So just to put a disclaimer out there, I'm not a social network analysis expert or researcher, but a practitioner. I have experience applying social network analysis in public health, and I attended a workshop a couple of years ago organized by this man, Steve Borgatti, at the University of Kentucky, and he is the industry leader of social network analysis research. I would like to show at this time the first 2 minutes of this video from University of Kentucky, in which Steve Borgardi briefly outlines the study of social networks and also its significance.
Social network analysis is basically the study of how people are connected to each other. What we study is a set of relations among a set of entities. It could be an organization, it could be country, it could be school. And what we do is map them and then construct metrics to try to characterize, like, what is the structure of that network, and try to figure out why does it have the structure that it does. We also look at the individual and see, so where is that individual located in that structure? It's hard to find something that is not organized as a network. If you're trying to understand something about the world around you, you kind of have to learn something about networks. They sort of act like pipes. And through a network, things can flow from person to person, particularly in organizations, which is what I study. It's how things get done. It's how work gets done. It's how we coordinate. You know, the 370,000 people that work for IBM, how do they all work together to get something done? It's through formal and informal networks. I mostly study centrality, which is the concept of the advantage that accrues to a node by virtue of its position in the network. So some nodes are more central, and there are certain advantages to that. So for example, one way in which you could be central is that you're not far from everybody else in the network. There are few steps in between. People like that tend to hear things faster. So if information is flowing through the network, they hear it early when they can take advantage of it. One of the things that central people have is that they're connected to lots of different parts of the network. And this part over here is talking about certain things, and this part is talking about certain things. And the person that happens to be connected to both can realize that the problem that they've got has already been solved by that group, and they can really provide a lot of value.
Great, thank you. So I hope that video from Steve Borgardi can give you a little bit of background and introduction of what he does with social network analysis. But I want to now go over some basic assumptions of social network analysis that we should always keep in mind. These assumptions can also be limits as well to social network analysis, because if these assumptions do not hold up for your various reasons that may be circumstantial to your organization or your coalition, your results will be less meaningful. So keeping these assumptions in mind is really important. So one assumption is that social network analysis assumes that people influence each other. There are different types of influences, such as kinship, which is saying I am a mother of or a husband of, or roles, like somebody is the boss of somebody or a teacher of somebody. There's also perceptual influences, like, oh, I know this person, or I have heard of this person. There's affective influences, like finding that you like somebody or that you trust somebody more than others. And then interactions, like giving advice to somebody, receiving funding from somebody, or working with somebody on joint projects. And there are affiliations as well, like belonging to the same organization or coalition, or being geographically near each other. Another assumption is the idea and material flow through relationships. So my organization at GW Cancer Center provides a lot of technical assistance. So we are interested in looking at how our technical assistance materials flow through our constituents and are used by the constituents. So here, social network analysis may be applicable to assessing how well we do that. And then the third assumption is that the structured relationship have consequences. So those things are definitely things to keep in mind. This is not an exhaustive list, but are things that perhaps may be most applicable to our realm of public health. And historically in public health, social network analysis has been used to assess the way infectious disease spreads, like HIV, or how social interactions between injection drug users influence negative health behaviors. So lots of applications in public health already, and this field is continuing to grow. So this is an example of a social network. Let's say it's a coalition, very much like the Hep B coalitions, made up of all of these different organizations. So we have organization A, B, and C here. This network map was created by asking the question, who do you send relevant information to? You can see which organization members send information to others by looking at the direction of the arrows on the map. So as you can see, member AS from organization A in the red circle on the very left-hand side sends information to TB from organization B. But AS doesn't receive any information from any other members of the coalition. You can see that the members in organization A also do not communicate well with each other because AS on the left does not communicate with JT on the very right. And really, none of them, AS or JT, do not communicate with the three red members at the bottom of the map either. So they don't communicate very well, and that's pretty apparent from this map. So this may lead you to conclude that AS or JT should not be taking on leadership roles like being coalition representatives for organization A, and that you need to probably create a more targeted individual approach to sending them news and information. On the other hand, when you're looking at organization C, which are the little circles in green, they have a very tight-knit network because they send information to each other very well. You can see all of the arrows pointing toward each other. And so this is an example of what they call a complete network, as each member in organization C is in contact with the rest of the organization members. So you may conclude from this that you only really need to tell one member of the organization C news and information that you may want to spread throughout that organization, because you can rest assured that they're very good at sharing with each other, and if one person knows something, they're very likely to share with the rest of the group. So this social network map can also be used to assess things like who you should interview when you are conducting needs assessments or coalition evaluation. So for example, JB from organization A, TB from organization B, and BD and PW from organization C might be key informants to ask about factors that facilitate information sharing, so you can leverage those factors more in the future to improve your coalition functioning. You may also interview people like JT, as we mentioned before, on the top right-hand side in red from organization A, who receives information from TB and organization B about barriers to communication. So that person might be good to talk to hear about, well, you know, what are some barriers that you experience in receiving proper communication from the coalition? You only have one person that could potentially send you information. How do you think we can make communication easier for you? So in this way, social network analysis can be very helpful for program or coalition planning, evaluation, and improvement. So just to tell you a little bit about my organization, GW Cancer Center, so that I can tell you a little bit more about how we use social network analysis in our programming. GW Cancer Center was awarded a 5-year cooperative agreement by CDC to provide technical assistance and training opportunities to support National Comprehensive Cancer Control Program grantees and their partners. And this agreement spans from 2013 to 2018, and we are currently in the 4th year, which ends at the end of the month. So we're kind of in a rush right now to get some deliverables out the door. And CDC funds cancer control programs and coalitions in the 50 states, District of Columbia, 7 tribes, and 7 U.S. territories. And they're tasked with planning, implementing, and evaluating cancer control activities. So these cancer control coalitions in particular are very similar to what I understand are Hep C coalitions that feature representatives from many different organizations that have a stake in a common cause. So as a part of this cooperative agreement from CDC, we organized Community Roundtable with the goal of convening key cancer and chronic disease stakeholders and strengthening partnerships at the community, state, or regional levels to promote increased integration efforts between the two groups. This was created in response to CDC's observation and direction for cancer control programs and coalitions to collaborate more with their chronic disease peers, because they found that there was some duplicative work, and they thought that by working together, cancer and chronic disease professionals could save resources and advance their efforts. And it makes sense to increase collaboration between cancer and chronic disease stakeholders because we know that they share common risk factors. And this graphic from Alaska's Department of Health really nicely shows those interactions with the risk factors. So our hope was that the roundtable meetings would provide stakeholders an opportunity to share their work, find some overlapping goals, and then work together on those mutually beneficial initiatives. And because after all, collaboration saves us all time and precious resources. And we partnered with the area health education centers, which there are more than 300 of them across the country, and they work to enhance access to care by improving the supply and distribution of healthcare professionals. And we thought they were great as agents to bring together cancer and chronic disease because they're a mutual entity and they have a community level connection. And we thought it would be good also because we found in a needs assessment that all AHEC representatives we interviewed said that they were neutral to not at all engaged in cancer control activities. So we wanted to get everybody in the same room. So we chose 4 area health education centers through a competitive application process to host these roundtables. And this map shows the location of the 4 roundtables in South Dakota, Vermont, Kentucky, and Florida. Each community roundtable was organized to convene once a year between 2015 and 2017 in person. And we also organized a 6-month follow-up call each year so that they can get together and discuss progress and any barriers and troubleshoot. So the AHEC, along with their planning committees, decided to select one chronic disease risk factor that will remain constant throughout the 3 years, and that will be the focus of the roundtable meetings. And they also chose one strategy that changes every year so that by the end of the 3-year initiative, they would have tackled their topic in a comprehensive manner. So at this point, we started to wonder, well, how should we evaluate these roundtables in a meaningful way? We administered standard pre and post meetings before and after the surveys, before and after the meetings. We got the surveys out to assess process outcomes and satisfaction, which is pretty standard and easy to do. But because the goal of the Roundtable is to convene key cancer and chronic disease stakeholders and strengthen those relationships at the community, state, and regional levels, we wanted to dedicate more time measuring whether we were able to achieve those collaborative connections. So this is where social network analysis neatly came in. We haven't completely analyzed the third year of the Roundtables quite yet, but in this presentation, I can show you some of the changes that happened in collaboration between the first and second year of the Roundtable meetings. So here's the type of survey we created for each Roundtable attendee to complete at each of the 4 locations. So on average, the Roundtables had 20 to 30 people in attendance. So the number of rows in this matrix was much longer. We asked each attendee about all of the other attendees, like how they know them, if they know them at all, how often they contact them, how often they send and receive information or technical assistance, and how much they trust them. So as you can probably tell, having attendees complete this matrix for 20 to 30 other people can take some time, which is actually one of the challenges of collecting social network analysis data. Another challenge I should mention is the completeness of the data, because good social network analysis heavily depends on high completion rates, which is something to keep in mind as you consider employing social network analysis to evaluate your Hep B coalition. So just to give you an example, let's say Harry Potter is completing the social network analysis survey that was created to assess the network of students at the Hogwarts School of Witchcraft and Wizardry. So he would leave the first row blank because we're not interested in Harry evaluating himself. So it's all 0 on that first row. Hermione Granger on the next row is Harry's best friend. So he would indicate her as personal friends. They also live in the same dormitory and share every aspect of school life together. So Harry would indicate that he and Hermione have contact exchange of information every day. And he would also indicate having a high level of trust in her. But on the other hand, looking at Draco Malfoy, he's a school bully, and Harry will maybe know him as a lab partner and have weekly or so contact with him out of necessity. But he may not share or receive school secrets or gossip with him, and he certainly will not have a high level of trust in Draco. So in this way, each network member will complete the same survey and assess their relationship with the other members of the network. The questions can be adjusted depending on the type of information you want to collect. So these are just examples of what we collected as a part of our Roundtable initiative and employed this strategy. So the Roundtable participants in 4 states, those were Kentucky, Vermont, Florida, and South Dakota. They all completed the online surveys before the Roundtables in 2015, and then again before the Roundtables in 2016. We used UCINet, a social network analysis software that was developed by Steve Borgatti and his colleagues, and we used it to assess changes in networks and working relationships. So as a recap, Roundtable attendees included cancer and chronic disease stakeholders, and they met in 2015 to share successes about their project and identify mutually beneficial activities that they can work together. And I will walk through what each of the 4 locations achieved between 2015 and 2016, and as well as what these collaborations, how they're reflected in the social network analysis indicators. So first, Kentucky, we went to Northeast Kentucky, and they brought cancer and chronic disease professionals together to tackle the common health effects of tobacco. The Northeast Kentucky region is highlighted in yellow on the map, and As we know, cancer professionals have a stake in tobacco because the tobacco use causes a number of different types of cancers, including lung and colon and cervical cancers. And chronic disease professionals also have a stake in tobacco, as it's been linked to heart diseases, asthma, and dental diseases. So those stakeholders got together at the roundtables and identified activities that integrate cancer and chronic disease interests. And here's a summary of what they achieved. So the Community Roundtable in Kentucky identified and incorporated local and national smoking cessation resources in St. Clair's Regional Center's electronic medical records, so providers can easily refer patients to the smoking cessation resources. They also developed and pilot tested the Brief Tobacco Treatment Specialist Training, which provides 27 hours of online training and includes content consistent with core competencies established by the Association for the Treatment of Tobacco Use and Dependence. So these are great outcomes from simply getting a group of cancer and chronic disease folks to communicate and to work together, but how is this reflected in the social network? Let's take a look. So here are the social network maps of how often they communicate. Again, the nodes or the roundtable members are the squares, and the relationships are denoted as the ties connecting the nodes. And the thicker the ties, the more frequently they reported communicating. The blue nodes are the cancer professionals, the yellow are the chronic disease professionals. Gray said they're neither cancer nor chronic disease, and often that could be people like business stakeholders, Chamber of Commerce people, or decision makers that may have also attended the roundtable. And white squares denote people that did not answer the question of whether they're cancer or chronic disease. And just by eyeballing this map, in this case, you might not be able to hone in on the developments of relationships between 2015 and 2016. So let's look at the data. Kentucky started with a very strong network. In fact, it was the strongest of the 4 roundtables that we organized. It helped that the Area Health Education Center that convenes the meeting was very well respected and integrated as part of their regional hospital and frequently partnered with academics. So the first indicator, which is average degree, tells us that a person on average knew over 6 other people at the roundtable in 2015 in Kentucky. This number actually went down the following year, but we actually expected this to a certain extent because new members were brought into the roundtable who may not have been well connected initially. In actual fact, for the Kentucky Roundtable, because the use of e-cigarettes became more prevalent and the concerns over their health consequences increased, Kentucky decided to widen their scope beyond just tobacco and bring on subject matter experts in e-cigarettes. So bringing in those new minds likely had an effect on the numbers, such as average degree. Similarly, average degree or average distance, between the participants also increased, which means that on average, the number of hops people have to make to get from person A to person B increased. So actually, the smaller the number, the better. So again, this is likely because new members were added to the roundtable in Kentucky who may not necessarily have been well connected. So both average degree and distance indicators tell us that the challenge for Kentucky over the following year would be to strengthen those new relationships. But as you can see, the diet reciprocity indicator increased, which means that communication between participants became increasingly more reciprocal and that the conversations between cancer and chronic disease was materializing. For Champlain Valley in Vermont, attendees actually renamed it as Champlain Valley Healthy Lifestyles Collaborative because they chose nutrition and physical activity as their topic. Their region is highlighted in yellow on the map, and as we know, cancer and chronic disease both have a stake because cancer, we know nutrition and physical activity causes a number of different types of cancers, like endometrial and colon cancers. And chronic disease professionals also have a stake in promoting nutrition and physical activity because it's been linked to a myriad of diseases like heart disease, diabetes, and stroke. And the roundtable attendees, again, identified activities that they could integrate and that they can both work on. And here's what they accomplished. They partnered with the Vermont Department of Health to amplify a communication campaign called 3450, which increases awareness of the benefits of physical activity. And the roundtable also identified a small to medium-sized employer and obtained commitment from them to incorporate 3450 as part of their worksite wellness initiative. So again, some promising outcomes, but how is this reflected in the social network? So here are the social network maps of the roundtables held in 2015 and 2016. And from eyeballing the map, you can tell that the chronic disease professionals in yellow are much better integrated in 2016 compared to 2015. Because for the 2015 map, you see all the yellows are on one side and the blues are on the other. It denotes a little bit of a divide between communication between the two. And the strength of ties, so the thickness of the lines in between all of the nodes is much thicker in 2016 compared to 2015. But let's confirm that by looking at the data. So Champlain Valley Roundtable actually had a weaker social network at the very beginning of the Roundtable initiative, but Roundtable participants appreciated the opportunity to share their programs with each other, and with some good leadership and commitment from all of the attendees, the number of connections per attendee increased dramatically. As you can see, it went from an average person knowing maybe 5 people at the roundtable to knowing 9 people at the roundtable, which is great. Similarly, the distance between the participants decreased slightly, so that means it took less effort to reach out to somebody who may know more about physical activity and nutrition in 2016 than it did in 2015. And then reciprocal communication also increased, which might inform future program improvement for Champlain Valley, which is that there needs to be increased engagement and back and forth discussion between participants. I'm sorry, reciprocity decreased. So it went from 0.38 to 0.21, which means that although people are making connections, they may not necessarily be starting to reciprocate the communication back and forth. A lot of the connection might be just one way right now. In Florida, they also chose physical activity and nutrition. They were able to get together at the roundtable and basically after the roundtable decided that they wanted to map the local resources for promoting nutrition and physical activity across the state. So they accomplished that. And they also decided to incorporate chronic disease projects as part of their 2-year strategic plan for the Southwest Cancer Control Collaborative. So it's nice to have a cancer-oriented organization or coalition look more to the chronic disease initiative to see if there are any overlaps and collaborate in the future. So although these precise outcomes for Florida have been limited compared to Vermont and Kentucky, the data for increased communication within the network showed some promising signs. And as you can see, it's pretty apparent from just looking at the social network maps that the network has become more tight-knit and more connections have been made, and the ties or the relationships have strengthened because you can see the lines are much thicker. And again, as you can see from the data, Florida started off with the weakest network of the 4 roundtables, perhaps in part due to the collaboration with the Southwest Cancer Control Collaborative. They were able to increase the number of relationships roundtable attendees have. And also the distance between the attendees decreased, which is great. And reciprocal communication also increased. And so from these types of findings, we can see that Florida should continue on this trajectory, continue to improve these indicators overall, but they can just kind of improve the indicators overall because they started with such low numbers to begin with. The fourth and last roundtable was in South Dakota. They also focused on nutrition and physical activity with a special focus on access. So the Northeast South Dakota region is highlighted in brown on the map. And what they were able to accomplish is something similar to Florida. They were able to map all of the diabetes prevention programs and local resources across the state and collaborated with cancer clinics to increase referrals to the diabetes prevention program. They ultimately produced an electronic referrals policy for clinicians to refer patients to the diabetes prevention program with the state health department, which is modeled after the smoking cessation referral policy. So looking at the social network map, it appears that the cancer professionals in blue are better integrated into the network in 2016 compared to 2015, but let's also look at the indicators. South Dakota started the roundtable with a very strong network, only second to Kentucky. And although the average number of relationships per attendee went down slightly from 2015 to 2016, these indicators mirror what attendees had told us, which was that South Dakota public health professionals, whether they work in cancer or chronic disease, have to communicate frequently to keep each other close because there are so many geographic challenges of working in such a large state that is mostly rural. So it's nice to see that the social network analysis indicators reflect what people have told us qualitatively. And the average distance between participants went up slightly and communication reciprocity went down. And these numbers likely reflect challenges South Dakota experienced with the Area Health Education Center leadership in flux. The South Dakota Area Health Education Center director stepped down between the 2015 and 2016 roundtables. So the position was vacant for almost 6 months, which significantly put a damper on engagement and implementation of activities. But again, it's nice to be able to see that the social network analysis indicators reflect the realities on the ground. So in this way, we at the GW Cancer Center used social network analysis to triangulate qualitative feedback and demonstrate the development of these relationships, which may be a priority for your Hep B coalitions as well. In addition to process outcomes and qualitative feedback from participants, as well as observed successes, we were able to use quantitative data from social network analysis to back up those claims, which is really helpful when reporting to funders and stakeholders. We also use social network analysis to monitor project progress, identify areas for improvement, and adjust program delivery accordingly. And although we did not do this for the roundtable, social network analysis can be used to identify missing stakeholders that could make the network stronger, or identify key stakeholders that could help you leverage their connections and influence in the network to further improve outcomes. So in this way, social network analysis can be very valuable to help you evaluate your Hep B coalition as well. I just wanted to, I recently realized that there were a lot of social network analysis work groups available and also conference workshops. And there's one coming up very soon by the American Evaluation Association. They're having a conference from November 6th to the 11th, and they have workshops on social network analysis from November 6th and 7th. And so those might be of interest to you. If you look at the slides later, you might be able to click on those and check those out. It's a conference, so it does have some fees to attending, But if you're interested in exploring this further, I think these are great opportunities for you to learn more about the theories, methods, ways you can use it to do some program monitoring and evaluation as well. I've also included some light reading, mostly journal articles that I think you can also access through the handouts section on your webinar app. So that you can dive in a little bit further if you're curious about how other people have been using social network analysis to benefit their work. So that's it from me. You can reach out to me by email that's displayed here with any questions or comments. I'd be happy to take them now as well and turn it back over to Kate.
Thank you. Actually, Kate stepped away for just a minute. This is Rhea Racho from the Hepatitis B Foundation, and I'm just going to help moderate some of the questions that have come in. And just as a reminder, if anybody still would like to ask anything, you can submit that through the chat box. So one of the questions we have was, how do changing levels of trust factor into the visuals that you were showing?
Yeah, so thank you for the question. The maps that I was showing you was just one of the questions that we asked in the survey, which specifically was, do you send information or technical assistance to these people? So the maps I was showing you is not incorporating the trust element. So we would have to do a completely separate analysis for the trust and generate a completely new social network map for those. But trust is interesting because the assumption is that if you don't have those trusting relationships, if there's friction or politics, you're not going to be able to collaborate well. So that's another way that we decided to map those to see what some of those barriers and facilitators are between personal relationships.
Okay, great, thank you. We had another question, a comment and a question, that the data for distance, degree, and reciprocity is great, but how can we, as organizations with low resources, complete these types of analysis with our own network?
That is the million-dollar question. As with, I think, any evaluation, we have to balance feasibility with the resources and the time that we have, and the value that the evaluation will bring to you, your organization, and the projects that you are working on. For our roundtables at the GW Cancer Center, because collaboration was such a central aspect of the success of our project, we determined it was worth the time and the effort and the resources to dedicate just to measure our collaboration efforts. This does take time. This does take some training, especially in using UCINET software or something similar for you to get literate in the software, but it's very well worth it if it's a priority for your organization to demonstrate the effectiveness of your coalition to your funders or other stakeholders and to propel your project forward.
Okay, and I guess as a follow-up to that, maybe do you have any estimate? There's another question that was very similar, just as a community organization leading a Hep B coalition, do you have an estimate of how much that time commitment or staff capacity is really needed to implement that full analysis?
Yeah, so
would it just depend?
That is tough. I mean, I think once you are trained, it's not that difficult. Once you're trained and you have the data, you run your analysis, and it, as any other analytic software, it spits out the results for you. I would say that the learning curve is pretty steep, but once you're once you're past that, I think the analysis is well worth it. And as I mentioned, the barriers for social network analysis should not go unmentioned. It's very time consuming to have, it puts the burden on your participants to have them go through all of those surveys, answer all of those questions. The results really depend on them completing the survey as fully as possible, and for most of the people in your coalition to complete it. So again, I think it's worth it if you are confident that you have committed coalition members that are willing to do that for you, and also for if you have your organizations or your coalition backing to dedicate the time and resources to get this done.
Mm-hmm. Okay, and there's one more follow-up question to that just came in. Is there a simple, easy mini analysis that could be done, or any lessons learned that organizations can apply without doing an analysis to cover our bases?
That is a good question. I'm not sure. It really depends on how big your coalition is. You might be able to do the survey and just by going through the answers from your coalition members, be able to surmise who the leaders are, who might be in the fray and might need more engaging. But in terms of being able to quantitatively show exactly how effective your coalition is from one year to another, for example, I think you would have to kind of get down and dirty with the data. But if I think of anything, maybe a shortcut or some simpler software, I will send that over to Kate and Rhea, and they can send that out to you all.
Okay, yeah, that would be very helpful. Thank you. I'm just looking through. I don't think looks like that was the last question, unless anything comes through in the next couple of minutes. But we really appreciate your time going through this in detail. It's a very informative presentation, so thank you. And we have contact information still showing on the screen right now in case anyone would like to ask any follow-up questions via email. We also, when the webinar ends, there will be a survey that pops up, and so we hope you'll take a few moments to fill that out to help us evaluate and get your feedback on the content and presentation of this webinar. We thank you all again for joining us today, and you will get an email with the recording of this session as well as the presentation slides and the handouts after this, and you're welcome to share the materials with other colleagues or partners. So thank you again everyone for joining, and we hope you all have a great rest of the day.